Good evening, everyone. Welcome to the new season of Mended Hearts of Coachella Valley. It's wonderful to see so many familiar faces and here in person, and we're equally happy to have those who are joining us via Zoom. For those who may be new tonight, I'd like to take a moment and share a bit about who we are. Mended Hearts of Coachella Valley is a local chapter of the Mended Hearts Incorporation. It's a national nonprofit organization dedicated for offering hope and support to heart patients, their families, and caregivers. Here in the Coachella Valley, our chapter works closely with Desert Regional Medical Center, Eisenhower Health, and of course, Eisenhower Desert Cardiology Center to provide peer pressure. Well, we do peer pressure too. Peer-to-peer encouragement to patients recovering from heart events and surgeries. We visit patients in the hospitals. We offer comfort and information to their loved ones and help them navigate recovery with understanding of compassion. In addition, our chapter proudly supports the next generation of caregivers through our nursing school scholarships, awarding annually at both hospitals an effort to help strengthen heart care in our community for the years to come. I'm truly excited to be starting another season together, a time of learning, sharing, and supporting one another. Mended Hearts is all about connections. Heart patients, families, and caregivers come together to offer encouragement, hope, and understanding. This year, we, with the support and partnership of Eisenhower Desert Cardiology Center and Eisenhower Health, have lined up an inspiring lineup of speakers and programs designed to keep us informed about the latest advances in heart health and to strengthen the peer-to-peer support that makes our chapter so special. Before we begin, here's how the evening's program will work. After Dr. Khanna's lecture, we will open the floor for questions. If you're here in person, please wait for the microphone before asking your questions so everyone, including those joining us via Zoom, can hear you clearly. For our Zoom attendees, you're welcome to enter your questions in the chat box and we'll share your questions with Dr. Khanna during the Q&A. Once all the questions have been answered, we'll conclude the lecture portion of our meeting and end the Zoom session. Those in attendance are welcome to stay and enjoy some goodies. After a short break, we'll resume with our support group meeting, a time to share experiences and provide encouragement to one another. Now, it's my pleasure to introduce our speaker, Dr. Khanna, a respected cardiologist at Eisenhower Desert Cardiology Center and Eisenhower Health, who specializes in the advanced heart valve procedures. His compassionate care and expertise have made a real difference in lives of many heart patients in our community. Dr. Khanna will be speaking on an exciting and innovative topic, replacing the aortic valve without open heart surgery. This breakthrough approach offers patients a less invasive treatment option with shorter recovery times and excellent outcomes. Please join me in giving a warm Mended Hearts of Coachella Valley welcome to Dr. Khanna.
Thank you so much for having me here tonight. I'd be remiss if I didn't first thank the volunteers at Mended Hearts. What you do is so important and contributes so much to the care of the patient, and I don't think you get acknowledged for it often enough. We were just talking about how when patients come in, they're anxious, they're worried, and I always like to say that knowledge is empowerment. And when these patients have interacted with the volunteers that have had heart procedures or have been through something before, the energy that they have about them when they come into the operating room is entirely different. And I promise you that that energy that they come into with them into the operating room affects their outcomes. I can tell you that after more than 30 years of doing this. So thank you for all you do. It's much appreciated and not acknowledged often enough. I'm going to take this evening to just talk about a way of replacing the aortic valve in the heart without doing open heart surgery. A lot of you are familiar with this. We've been doing this here for about 10 years. It's called Transcatheter Aortic Valve Replacement, or TAVR. We'll just go through some slides and talk about this. Let's see. No? Maybe I'll try this. I think I need my AV help. That's supposed to work? Yeah. Oh, you just had to walk up to me, that's all. Yeah. So our Eisenhower transcatheter valve program is led by our valve clinic coordinators, Crystal Hastings, Julia Powell, and Tara DeGrazia. These are the nurses that keep everything running smoothly. We show up and do the procedures and take the credit, but they're the real power behind the entire program. They get everything scheduled, they get CT scans done, they are the constant communication with patients. And this program couldn't succeed without them. So I have to first mention them. We have 4 interventional cardiologists that do this procedure now. Dr. Frutkin and I started the program about 10 years ago. We hired Dr. Pangaluri about 5 years ago, and he came out of Scripps in San Diego after doing 5 years of cardiology, 3 years of general cardiology, and 2 years of interventional and structural heart training. And then after him, we've hired Dr. Sharma about 2 years ago, who is also very facile and very well trained in structural and interventional cardiology. So those are the 4 interventional cardiologists in the group. We've got 2 great cardiac surgeons, Dr. Wilson, who's been here just about as long as I have, and then Dr. Logsdon, who also joined us about 4 or 5 years ago. So our index patient, our first patient that we did 10 years ago, was 92 years old. Okay. Interestingly, when we did his valve, this procedure was only approved for patients that were not good candidates for open surgery. That was the only indication for which it was approved, or the risk was so high with surgery that it was considered to be prohibitive to even operate on these patients. It's a 92-year-old gentleman, very much with it, very active in his community, was kind of limited by some arthritis in his knees, was becoming increasingly short of breath, and got to the point that he wasn't even playing golf anymore. And we admitted him to the hospital once for heart failure, made his diagnosis, and said, you know, we're doing a new procedure, which we think you may benefit from. And these patients, all our patients that have a TAVR are looked at by the entire heart team. It's not just me that evaluates them. It's the surgeons. We do CAT scans. We have our general cardiologists that look at these patients and help us with echocardiograms and transesophageal echoes if that's what's needed. So the entire team looked at this patient and said, yes, this is a really good candidate for doing this procedure. So we did his first, we did our first TAVR at Eisenhower Hospital in April of 2015. So we're a little more than 10 years into our program here now. He was discharged from the hospital after a 2-day stay. His symptoms of heart failure resolved completely. He was actually able to complete cardiac rehab. And for those of you who have been through cardiac rehab, you know you're in pretty good shape by the time you finish cardiac rehab, even if you weren't when you started, right? He was doing so well that he went back to playing golf, and after 3 months said, my bad knee is interfering with my golf game, and he came back in and had a knee replacement. All right. So he's continued to live independently. He passed about 2 years ago, but did really well after his valve replacement. Died of non-cardiac issues, something else, but heart-wise he was fine. So we'll briefly talk about tonight what is aortic valve stenosis, what is the clinical course of this disease if it's left untreated, what transcatheter aortic valve therapy brings to the table for these patients, and then what we have done and are doing in our valve program. So this is just a diagram of what a normal valve looks like. And the normal valve, when it's closed, looks like a Mercedes sign. It's got 3 flappers. And when it's closed, it looks like that. When it's open, it looks like that. When you have mild aortic stenosis, you start to get scarring along the leaflets, and the opening becomes a little more restricted. As it gets worse, it becomes moderate. It starts looking like this when it's closed, and this when it's open. And then when it's severe, it starts to look like this. And this is an actual picture of a valve that has severe aortic stenosis. And you can see all these little nodules, these little round structures. These are actually calcific lesions that have restricted the motion of the valve, right? So it's become hardened and it doesn't open normally. So most of these patients present with one of 4 things. They either start to have chest pain, tightness in their chest when they're walking or exerting. They start getting short of breath. They start to get lightheaded, dizzy. Some people will actually pass out, and then some people will have abnormal heart rhythms. The reason for all of this is that there's just not enough blood coming out of the heart, right? In a normal valve, when you look at it from above, it's a little smaller than a quarter. And these patients, by the time they develop symptoms, have a valve that's about half the size of a dime. So your heart's working over time to push blood through a very narrowed orifice. And right above this valve is where the circulation of the heart comes off. So these arteries don't get enough blood, so the heart muscle doesn't get enough blood. So when people exert, they start having angina, they start having chest pain. Because there is such a narrowed opening on the outflow of the heart, as the heart pumps, it's pumping against more and more resistance. The blood begins to back up in the lungs, and the lungs become boggy with fluid, and you can't get enough air, and you start feeling short of breath when you exert. So all these symptoms are very physiological to the disease process. If the aortic stenosis becomes severe and there's not enough blood getting to the head, people get dizzy, they get lightheaded, they pass out. And the other symptoms are fatigue because you're just not getting enough blood to the body through this very narrowed opening. When we examine these patients, we hear what's called a murmur, a systolic murmur. Many of you may have heard this term. The simplest way I can explain a murmur to you is if there's water coming out of a garden hose and you stick your thumb on the hose, the water comes out faster. That's exactly what we're hearing on the valve. When the valve gets narrowed, this velocity of blood flow coming out of that valve increases, and that's what we hear. It's a whooshing sound. A normal valve does not make any sound, right? It makes some clicks, but you don't get a whooshing sound, and that's what a systolic murmur is. So as a physician, when you hear this, when you examine the patient, that's your first clue that something is amiss. The heart sounds themselves become soft or absent because the heart sounds come from the clicking of the valve together. And because this valve is restricted, that clicking, normal, pliable motion of the leaflets is restricted. And then you also have a delayed upstroke in the pulse of the patient, which as you become more experienced as a clinician, you start to pick up. Here is an echocardiogram. This is an ultrasound of a normal looking valve. You see these 2 little leaflets here, they're opening and closing. So it's this portion here. This is the aortic valve. And this is what it looks like when it's actually beating. When you look at it at 90-degree angle from this, it looks like that Mercedes sign that we talked about. And this is what it looks like opening and closing. Now, here is a bad valve. You can see how it's hardened, it's calcified. It's not opening and closing like it should. And you can see over here what it looks like at a 90-degree angle as well. So those are echo images. So when we do a physical exam, we hear a heart murmur, the next thing that happens is we send the patient for an echocardiogram, which is an ultrasound of the heart. Put a little jelly on the chest, we rub the chest with a microphone that bounces ultrasound waves off the heart, and that's how we obtain those images. Not only can we obtain those images, we can also make measurements, very exact measurements with these echocardiograms. We can actually measure the speed of blood flow coming out of the valve. And we know that when that speed of blood flow is over 4 meters per second, that patient has what we call severe aortic stenosis. If your peak gradient, meaning the pressure drop across the valve, is more than 60 millimeters of mercury, that's severe aortic stenosis. If the mean gradient, the mean drop in pressure is 40, or the valve area is less than 1, and these are all measurements that we can obtain on our echocardiogram, non-invasively, right? Just with an ultrasound on the chest. These are the measurements that qualify for severe aortic stenosis and are an indication for us to treat the patient. And what is the survival after onset of symptoms? I should actually skip this slide because there's a paper published just 6 months ago that has changed the whole paradigm of waiting for symptoms in patients. We actually now do not wait for the patient to become symptomatic if they have severe aortic stenosis, meaning if they have any of these measurements, whether they have symptoms or not, we're now talking to these patients proactively about moving forward with treating the aortic stenosis, right? But what we do know is that if you don't treat a patient that has severe aortic stenosis, 50% of these patients will die within 2 years. So this is a serious problem. It has a prognosis that is actually worse than a lot of malignancies, a lot of cancers. And the good news is that if you treat this, your outcomes, the patient basically has a longevity that is the same as someone that never had a heart problem, right? So it's a mortality benefit that is immediate and reversible. There's a few different ways that you can treat aortic valve stenosis. The traditional way is the open chest or the sternotomy procedure. And what we do here is we actually cut the chest open, and we have great surgeons at our hospital. Both Dr. Wilson and Logsdon do a wonderful job with this. The patient is under general anesthesia. We put them on what we call a heart-lung machine, and that machine does the work of the heart and the lungs, right? And what we do is we pack the heart in ice. We inject it with potassium. We stop the heart. We cut the heart open. We cut the valve out. We kind of size the valve with different size cylinders. We got 24, 26, 28. Okay, give me a 28. Give me a 26 valve. We suture that in. We close the heart. We suture the heart back together. We jumpstart it with paddles. And we slowly wean the patient off the heart-lung machine and let their heart and their lungs take over. This is all happening in the operating room with the chest open. And then when the patient's being able to function on their own, we disconnect them from the heart-lung machine and we close the chest with in multiple layers with stainless steel wires on the sternum, right? And that's how it's been done for many years, and it's been very successful with very good outcomes. Mortality rates with this approach are in the 1%, 2% range when you pick your patients carefully and everything goes well. So it's a very safe and very good procedure, but obviously it's a more invasive procedure than what we're using right now for a lot of our patients. You can actually do the same thing through a right anterior thoracotomy. And what that is a sort of a miniature incision that allows you to replace the valve. Some surgeons like doing this and some don't. This gives you a limited exposure, but so you don't have the open field that you normally have. It is less of a problem to heal from, but it's harder for a surgeon to do this because he's working through a smaller opening and they have limited visibility, right? And it was done for patients who were low risk, and we had the same outcomes, right? So now, in today's world, this procedure is actually approved for all patients who have severe aortic stenosis, whether they're low, moderate, or high risk, right? You can stop there. That's fine. I'll just backtrack a little bit and talk more about where we are from a standpoint of the prevalence of the disease. And there's 250,000 people who meet indications for valve replacement every year in our country, right? Not a small number, 250,000 people. Usually, the statistics have shown that about 80 to 90,000 patients actually get surgery. Well, what's happening to the rest of them? 2 out of 3 patients would never get operated on because they were too old, they were too sick, they had bad lungs, they were felt to be too high risk to be operated on. And so what we did for these patients was, well, we're going to try and keep you comfortable. And eventually these patients would pass from their aortic stenosis, right? So here are the reasons: older age, frailty, severe heart failure. Some of these patients had had prior bypass surgery and now they had a bad valve. Well, you're going to do a second open heart surgery on a patient who's, 83 or 84. That's a whole different challenge in and of itself. Sometimes the aorta itself is heavily calcified, so the calcium is not just in the valve, it's gone into the aorta as well. And so when we do one of these operations, we cross-clamp the aorta. So we actually put a clamp on the aorta. If your aorta is calcified, it shatters, it cracks, and now you're in real trouble, right? So if you know from a CT scan that there's a lot of calcium in the aorta, then that's not a patient you want to operate on. If a patient's had, renal failure, kidney disease, if they've got bad lungs, opening that patient's chest is not the best idea. Your operation might be successful, but you might not be able to get them off the ventilator post-operatively. They don't recover well. So these are all reasons why patients would not have surgery, right? So here's the trials that I was talking about. 2011, we got FDA approval for patients who were prohibitive risk. 2012, we got approval for patients who were high risk. And in 2016, we got approval for intermediate risk. And in 2019, we got approval for patients who were low risk. And there's hard scientific data that shows that this therapy is equivalent or better than open heart surgery, right? So it's not, oh, we think this is a better way. We have hard data to support that, not just a patient experience, not a collection of patients, but random assignment of patients. So you took a patient who could either have surgery or could have a TAVR, and you put your hand in a hat and you picked out what they were going to have. And this is what we did for all of these groups of patients, right? And in each group, we had equivalent, if not better, results with TAVR, which is why it's become such a widely adopted therapy now. Obviously, the valve replacement done from the groin is less invasive, and you're able to deliver the valve to a beating heart. So in patients who have blocked arteries in the legs, so normally these red lines you see here are the arteries in the legs, and these go all the way up to your heart, and this is where we normally go. We go in from the groin, we track the valve all the way up under X-ray guidance into the heart itself and deploy the valve. Now, there are some patients who have what we call peripheral arterial disease, meaning these arteries in their legs are blocked up with plaque, and they're not large enough for us to accommodate our equipment. So we can't get our valves up to the heart through the legs. Well, we found different ways to approach these patients. So one way was to go through this artery that sits underneath your collarbone. It's called the subclavian or the axillary artery. And we did about a half a dozen with this approach here. There's a transaortic, which is sort of similar to the mini sternotomy, where you actually cut right next to the sternum and you go directly into the aorta with your delivery system. And we did, I think, 4 of those here. There's a transapical, which you actually go in between the ribs and you go directly into the heart itself, right? You deliver through the apex of the beating heart, the valve into the old valve, right? So these are all different ways to try and get the valve to where it needed to go. And what we found, at least in our hands, is the best approach has been a transcarotid approach. So the carotid artery is right here in the neck, right? It sits underneath right underneath your skin, usually about a quarter to half inch below the skin. You can actually feel it if you put your hand on your neck and you turn your head a little bit, right in line with your Adam's apple, you'll be able to feel the pulsation. So we make an incision that's about an inch long. We actually expose the artery and we put our catheter in from there to deliver the valve. and we close when we are done, we take our catheters out. We put 4 stitches in to close the artery. We close the skin, and the patient has a new valve with an incision about that big in their neck that heals in about 7 days. We've actually done 150 or so cases with a transcarotid approach. We are one of the largest transcarotid centers on the West Coast now. Our surgeons regularly fly out all over the country to train other surgeons on how to do this, right? And again, if we go back to when we did our first transcarotid, this was early in our program. We started this program in 2015. I think it was 2018 that we did, either late 17 or early 18 that we did our first transcarotid. And it was a patient of mine, and he had really badly blocked arteries in his legs. He had bad lungs. He was not a good candidate to do open surgery. And I said to him, the only way we can approach you is to go from your carotid artery, and it's going to take me a bit to get things set up to where we can do this. Because the way I wanted to do it was to make sure that we could do it in the safest way possible. And at that point, the only literature on it was a series of 120 cases that a surgeon and a cardiologist together had done in Europe. And what I did was I got it set up to where we could fly the surgeon out from Europe to come and help us with that case. So this took about 2.5 months of planning. My patient was getting a little upset at me, told me he was going to go to Loma Linda or to Cedars. And I said, you know what, if they can do it, go get it done. And he went to both places after he called them, and they said, oh, yeah, we do TAVRs all the time. Come on down, we'll take care of you. And he took all his studies with him. And they said, oh, no. The only way you can get done is transcarotid, and we don't do those, right? So we actually did our first transcarotid case long before Cedars, long before Scripps, before any other hospital in Southern California had done one, right? And our surgeons adopted the technique. They were with somebody that had done a bunch of these cases, and it became part of our repertoire, and our ability to take care of patients improved that much because of it. So that's kind of how the program has grown, right? It's driven by patient need. It's driven by cases, and we become more experienced and more facile and better at what we do with every patient that we treat. So there are different valves that are currently available in the US. There's 3. Increasingly, we started with this valve, the transcatheter valve from Edwards, right? Edwards Life Sciences. It was called the SAPIEN 3 valve. And we have stuck with this platform from day one. I had a choice of picking 1, 2, or A, B, or E. I looked at all 3 of these when we were starting our program, and I was convinced that this was the best platform to go with. And the last 10 years has proven that to be the case. This valve is now the market leader in the country and in the world. In the US, they own about 75+% of market share, right? The rest is Medtronic, and then there's 1 or 2 more valves that are coming. There's a lot of other valves that are available in Europe, but even in Europe, this is the valve that dominates the transcatheter aortic valve replacement space. So this is what the valve looks like. If you put it in your hand, just to give you an idea of the size. It has a stainless steel frame. The white part that you see outside here is a fabric skirt that actually helps seal the valve and keeps any leaks from happening around it when we deploy the valve. And on the inside, the yellow that you see are 3 flappers made from the lining of a cow's heart, what we call the pericardium of a cow's heart. And this is built by hand in Orange County at the Edwards plant. We've actually gone down there, and there's a line of people sitting there hand sewing these valves and putting them together, right? And when they take this pericardium, this lining of the cow's heart, it basically takes for each leaflet, you end up using 1 cow. because you have to have a certain thickness of the pericardium. The thickness has to be within specific constraints. You have to have all three leaflets matching in thickness and matching in size. So they're very particular about their quality control and how this is done. Because when these valves are put in, they're benchtop tested first, right? So what we do is when we're putting a valve in a patient, well, how do I know am I going to get 2 years? Am I going to get 5 years? I mean, at the end of the day, it's a piece of engineering. It's got to fail at some point. Am I getting 10? Am I getting 15? Am I getting 20? I don't know, right? Surgical valves have been implanted for many, many years, and we know that we can get 12 to 15 years out of a surgical valve. So our goal is to get the same out of these valves, at least, if not more, right? So the way they test these valves is they take 1,000 valves like this, and they put them in a closed system where you have a pump pumping blood through the valve. So the valve is opening and closing. Well, it's not blood. It's fluid that has the same viscosity as blood. And the pressure at which it is pumped is the same pressure that you would see inside your heart. And these things are run 24/7, right? And instead of running them at 60 beats a minute, which is your normal heart rate, they run them at 300 beats a minute, right? So 5 times the normal heart rate, meaning if I keep it running for 1 year, that's the equivalent of 5 years. So they keep these things running for 3 to 5 years. So they run them for 20 years, equivalent. And every day they go and see which valves have failed and how many have failed. So you know exactly on the bench top what these valves are doing. And that's how the surgical valves are tested before they go into patients. So there's a parallel there, right? And at least on the bench top, we know that these valves do just as well. And that's now proving to be the case as we put them in patients as well. I mean, we've got people that are 10 years out here that are doing well, right? And this is our delivery system. So this is the balloon when it's expanded with a valve on it. This is the balloon when it's not expanded with the valve crimped on it. This goes through a tube that's about the size of my index finger. That goes into the artery in the groin, right? We take this catheter all the way up around the arch and deliver it into the heart. So this is a simulation, an animation. Here's my balloon. The balloon actually sits outside the valve when it is crimped. We bring it up here, we bring the balloon back inside the valve, and then we advance the entire system over a wire up and around. And here's your bad valve. Your bad aortic valve is sitting up here. So we bring this around from the groin, around the arch. We bring this inside the bad valve, position it carefully, and then we expand it. You'll see here. And as it expands, the white part is the fabric skirt on the outside that seals any leak that might happen. So your valve is now implanted and fully expanded. We deflate the balloon and we bring the balloon out, and you have a functioning heart valve. All right. So the one part I missed over here to mention, and I'll sort of just go over that really quickly. When I am putting one of these valves in, my margin for error is about 2 millimeters, right? That's the zone in which I have to land this valve. If you think about it, if you have a beating heart and the heart's going at 60, 80 beats a minute, that's a moving target. I'm never going to land my valve where it needs to land. So what we do is we put a temporary pacemaker in the heart, and we speed the heart rate up to 180 beats, 200 beats a minute. So the heart, instead of beating like this, is now laying there doing this. And that's what you saw in the animation when the valve was being deployed. And that is basically the heart in standstill for 30 to 60 seconds. And I can do that for 30 to 60 seconds without any deleterious effects on the patient. But in those 30 to 60 seconds, I have to position my valve and expand it. Right? So it's a little bit of a choreographed dance that we do. It's a little bit of a roller coaster ride. You kind of slowly go up, and then there's 15 seconds of, whoo, here we go, right? But we've done, I think, over 1,600 cases now, and it's been a great journey. So here's the actual X-ray deployment. So here's the valve. You can see it sitting here in the aorta, and that's the valve being expanded. Here's my temporary pacemaker down here. And you see it's expanded, the balloon is deflated, and the balloon comes back. So it's just a loop playing. And that's an echocardiogram of the valve after it's deployed. You can see it's got nice thin leaflets that are opening and closing. You can see it's now a normal looking Mercedes sign that you see with a normal valve, instead of that hardened calcified valve that you were looking at before. This is what the groin incision looks like when we go in. We actually deploy sutures from the outside to the inside of the artery. So these sutures, the artery may be as much as an inch, inch and a half below the surface. We're actually able to deploy a suture that goes into the artery, into the lumen of the artery, and then comes out on the other side of the artery where our incision is. And so we have two sutures sitting outside on the skin. We deliver 2 of these sutures, sometimes 3 of these sutures. And after we get done, we take our catheters out, which are about the size of my big index finger. We're able to basically cinch these sutures down, push them with a knot pusher all the way down to the surface of the artery, close the incision. And when we're done, the patient has an incision in their groin that's about the size of my fingernail. Okay. So these are the clinical trials. I won't bore you with this, but these graphs basically show that these are called the partner trials, cohort A, cohort B. This is the statistics and the data of the clinical trials that I was talking about. The yellow lines are TAVR patients done with the SAPIEN valve, and the blue line is surgical patients. So you can see how they diverge, and the mortality rates are lower with the TAVR cases. Cohort A was the high-risk patients, and you basically had an equivalent outcome at 2 years in the highest risk patients. So there was actually no reason to operate on a high-risk patient. It was clear that you'd be better off doing them with a TAVR anyway. And today there is no high-risk patient that gets done surgically unless they're just not a candidate for a TAVR, right? So the outcomes of the partner trial, which is the sort of the pivotal trial that made things, possible for us to do this for patients, it substantially reduced mortality in patients. 4 out of 5 TAVR patients had minimal heart failure symptoms after the valve was done, and procedural complications of TAVR were very infrequent, right? So you can imagine having to heal from a big sternotomy incision compared to a quarter-inch incision in your groin. It's a very different story, right, from a recovery standpoint. So here's intermediate risk patients. Again, similar data. You can see where the yellow line is and where the blue line is for TAVR. Again, equivalent, if not better outcomes when you looked at mortality or you looked at disabling stroke. Intermediate risk patients, same thing, 20% risk reduction in these patients. And then the low risk trial actually showed TAVR to be superior to surgical valve replacement. So this is more of the same data. This is looking at just death or disabling stroke, which are very hard endpoints. There's no fudging those numbers, right? And so you can see it was 2.9% for surgical valve replacements and 1% for transcatheter valve replacements. And here's sort of a look at the improvement in symptoms going from class 3 or class 4 heart failure, how much of an improvement there was, the 6-minute walk distance for these patients, the KCCQ, which is the Kansas City quality of life scoring system that shows a consistent improvement in patients' quality of life. And again, mortality as well, significant improvement. So what's happening across the country, across the world, is that TAVR is growing. Surgical volumes are we're staying pretty steady and then have started to now drop off as more TAVR comes into play, which was to be expected. And increasingly, more and more patients that are being done are in the low risk, moderate risk categories. Days to hospital discharge. Most of our patients, probably 95% of our patients, are going home in less than 24 hours. They come in, they have their valve done, they go home the next morning, right? In fact, we did a transcarotid yesterday. We finished that case at 9 o'clock. No, we finished, 9 o'clock in the morning yesterday. Patient was discharged at 10 o'clock this morning. Walked out, yeah. So, and the vast majority of these patients, 90% of them, are going home. They're not going to rehab facilities. They're not going to extended care facilities to recover from, a big surgical incision, right? And that's really key, really important. So all your risk profile patients, the low risk, the intermediate risk, the high risk, are basically good candidates for this therapy, right? And so when we're talking about high risk, we're talking about patients whose chance of dying on the table is about 10%. Intermediate risk is at 6%. Lower risk is at about 2%. But in all of these subgroups, TAVR has proved to be superior, if not equivalent. So our heart valve program, our mission is really to evaluate and appropriately treat patients who have complex cardiac valve disease. We've got a multidisciplinary program. We have our general cardiologists, interventional cardiologists, cardiac surgeons. The radiologists help us with the CT scans and imaging. This is our heart team, so everybody that's involved, right? And then it all comes down to, in the operating room, deploying the valve. I think this might have been one of our first cases that we were doing. And these were done in the cardiac cath lab when we started our program. So through our heart valve clinic, you confirm your diagnosis by exam, by echo. You get an angiogram and a heart cath that confirms how bad your aortic valve disease is and allows you to see if you have any blocked arteries at the same time. We will usually fix the blocked arteries before we fix the valve. Part of the reason for that is that when you're doing a TAVR, you have to speed that heart rate up to 180, 200 beats a minute. And if you're dealing with a blocked artery and you do that, you risk precipitating a heart attack. And you don't want to be doing that in the middle of a TAVR, right? So we'll fix those blockages with a stent and then do the patient's TAVR a week or 2 weeks later. We do CT imaging to look at their vasculature, their arteries in their legs, and all the way up to the heart to make sure there's nothing that would limit our ability to deliver the valve. And then every Wednesday morning, what we do is we sit down and we discuss all of these patients. Every patient is seen and evaluated by a cardiac surgeon, is seen and evaluated by an interventional cardiologist that does TAVRs. And their echoes, their CT scans, their angiograms are pulled up, and we look at every study on every patient, and every patient gets discussed. And we as a team recommend what we think is the best therapy for them. Is it surgical? Is it transcatheter? If it's transcatheter, are we going femoral? Are we going carotid? All that gets decided. And then we just call the patient and say, hey, this is what the team thinks is best for you, right? So we've already talked about different ways to treat the aortic stenosis. This slide is a little outdated. So this is 2023. We were at about 170 patients. Last year, 2024, we were at 230 patients. This year, we are projecting somewhere between 250 and 275. There is a way to actually pull up the Medicare databases and see what the incidence and diagnosis of aortic stenosis is in the zip codes that we cover. My projection is that 3 to 4 years from now, we'll be doing somewhere between 400 and 500 cases a year. That's how much room there is for growth, right? And there's a need for it for these patients. Almost all our patients now are being done without anesthesia. We bring these patients in, we give them sedation, kind of like what you might get for a colonoscopy. So you're asleep, you're not aware of what's going on, but you're breathing on your own. There's an anesthesiologist there, and we can convert to general anesthesia if we need to. We hardly ever need to. Hardly ever need to. When we get done with the procedure, about 10 minutes before we are finishing, the anesthesiologist turns all the sedation off, and I'm able to talk to the patient on the table. And the patient comes out of the operating room on a stretcher, awake, talking, and with no big incisions to show, all lines out basically, right? Our mean procedural times now are under 60 minutes. When this slide was made, it was under 70 minutes. The fastest case we've done, skin to skin, is 14 minutes. 14 minutes, right? It's just because our entire system is now debugged. We've made a conscious effort to build a program where we are efficient with this, right? When we started out, the first TAVR I did took me 3 hours and 45 minutes. It was done under general anesthesia. We did it like it was a open heart surgery procedure, right? The patient had a Swan-Ganz catheter, a Foley catheter for their urinary bladder. They had lines in where we could give them all kinds of medications. And what we found is it's actually safer and better to do it with less sedation. Patients recover much faster. They don't have the effects of general anesthesia. And they do much, much better if we do it that way, right? So we're well over 1,600 cases at this point in the program. We are a benchmark program, which means we are in the top 7% in North America. We are the only site in the country that Edwards, the manufacturer of the valve, has picked as a site where we do live demonstrations. So there are teams flying in to watch us do cases on a regular basis, right? Yesterday, we had a whole team come in from New Mexico. So we had their surgeons, their interventional cardiologists, their scrub nurses, their x-ray technicians, the director of their cath lab. They came in to watch us do cases. Not that we're showing them how to do a TAVR. They know how to do a TAVR, but we've achieved efficiencies and we have outcomes that compare with or beat the best institutions in the world, right? And so what we're being able to do is we're being able to do 6 to 8 cases on a Wednesday, starting at 7 in the morning, 7:15, 7:30 in the morning, and by 2 o'clock we're done, right? Yeah. So it's a nice little feather in our cap, you know, for a small community hospital to have built a program like that. 2 weeks ago, we received a request from Mayo Clinic Rochester to come out and watch us. All right. So I think we must be doing something right. Yeah, our transcarotid cases are close to 150 at this point. The other thing that we are doing is that we are now doing a lot of valve-in-valve cases, meaning if a patient had a surgical valve implanted 10 years ago, 15 years ago, and that valve has now begun to fail, instead of having a second open heart surgery, what we're able to do is we're actually able to go in and put a TAVR valve inside the previous surgical valve. So it becomes a And those cases are actually even easier to do than patients who have native aortic stenosis because the surgical valves are so clearly visible under X-ray. We've done this not just for valves that are in the aortic position, we've done this for valves that are in the mitral and in the tricuspid position. So in the mitral position, what we do is instead of going into the femoral artery, we go into the femoral vein. We go up the right side of the heart, and we actually puncture the septum between the left and the right atrium, the two upper chambers. We put our valve through the hole that we create there into the mitral valve, deploy a TAVR valve in the mitral surgical valve, and come out. Right. So you've got a patient who is, 15 years out from having had a prior valve replacement that we're now being able to fix without doing another open heart surgery. And these patients stay one night and go home the next day. So this is a simulation of an aortic valve in valve. So you can see the surgical valve is this white structure here. And what we're doing is basically deploying a TAVR valve inside the surgical valve. This is actually a live case of a patient who already had a surgical valve. And the valve is degenerated. You can see all this color flow here. The valve is leaking. You shouldn't be having all of this color flow here. And so we go in. This is a patient who had severe aortic insufficiency, had a surgical valve in year 2000, now has heart failure, needing diuretics to stay out of trouble. And you can see the surgical frame. See this wire here, the coils? And we're expanding a TAVR valve inside that surgical valve. Now, sometimes it happens that these surgical valves are not easy to expand because they're made out of stainless steel, most of them, right? And if the valve is too small, we need to put a bigger valve in. We have actually fractured some of these valves. So we use a balloon that's made out of Kevlar, and it can go up to 80 atmospheres in pressure. To put that in simple terms, that's about probably 20 to 30 times the pressure inside your car tire. And so what we will do is we'll go in and we'll fracture the frame of the surgical valve, and that allows us to expand our TAVR valve to the size that it needs to be expanded to. But when we're doing these cases, we have ways of simulating what's going to happen with that valve when we fracture it. Because as you can imagine, if it fractures in the wrong way, you can create a lot of damage doing that, right? So it's very controlled. It's a little bit of an adrenaline rush when you're doing those cases because you can actually hear the valve snap when you break the frame, right? But we've done a lot of these just because that's our patient population. We have a lot of patients who've had prior surgery here, and we've done really well with it. So this is now going into the mitral. So here we're going transseptal. This is the interatrial septum. And this is our delivery system coming through the interatrial septum. And what we're doing here is delivering the valve into the mitral. So you'll see this. This is a live picture on the echo. You can actually see the valve is degenerated. It's leaking. And so this is us coming across the septum, delivering our valve into this frame, which is the mitral position. And we expand a TAVR valve over here. This patient actually has an aortic valve and a mitral valve that is artificial from previous surgery. So it had a double valve surgery 15 years earlier. And so now you can see that valve, the new valve is in. All that leak that you were looking at has gone away. You can see the leaflets of the valve are thin and opening and closing like they should be. And that's what we want to see. So that's our valve clinic. That's our valve program. I'll stop talking and take questions.